Hey, everybody, welcome to Dental Voice with Xyrus. My name is Rolando Mia, and today we have a special guest. Everybody, meet Dr. George Holzer. Not only is Dr. Holzer an incredibly knowledgeable dentist with many years' experience, he is a retired colonel in the U.S. Army. Thank you so much for your service, Dr. Holzer. Because of what you do and our armed forces, that we get to do what we want. Anyway, the topic that we're going to be covering with Dr. Holzer today is this context of bridging two worlds. Basically, the transition from dentistry in the military to dentistry in the private sector or in civilian life. Dr. Holzer, thank you so much for joining us. Really appreciate you coming here. How are you, sir?
Rolando, I'm wonderful. I want to thank you for the invitation. I want to clarify one thing. I bridged first from the civilian sector to the military, and then because I did 2.5 years of private practice before joining the military, and then from the military out.
Holy cow. And or you worked in the military for over 24 years. Is that right, sir?
Yes, started in March of 1991 and retired in May of uh, 2015.
Holy cow. I believe the last function you have, you were the chief of restorative dentistry and you were responsible for, oh my goodness, an incredible program that you'd built over those many years.
Well, thank you for that. I did serve time as the chief of restorative dentistry in numerous locations, never for the whole Army as a whole. And my last real job before I started my retirement glide path was working as the residency director at Joint Base Lewis McChord near Tacoma, Washington.
Oh, how cool. So let's jump into this. When you look at dentistry overall, you've got the experience, I mean, of having had and have been working in the private sector or in civilian life as well as the military. How would you kind of summarize the difference between dentistry in the military and dentistry in civilian life?
It's a great question. I mean, there is a lot of similarities between military dentistry and civilian dentistry. I mean, it's dentistry.
Right.
We've got a lot of rules and I won't call them regulations, but rules in the military. And I'm going to list two here as an example. Uh, when we do restorative procedures in the military, you don't do a restorative procedure without some type of isolation. It used to say rubber dam.
Period.
Rubber dam was the only thing we could use. But they've come on board, and things like an ISO-Lite or ISO-Dry is now very much an acceptable form of isolation for restorative. The funny thing is, you go back to when I was in dental school, and we were told this is the right way to do dentistry. And I graduated dental school in 1988. Back then, amalgams were quite common, and you could do amalgams almost underwater. We used to call them submarine dentistry.
Right.
But with today's new materials, composites, bonding agents, they do not work well when wet. They don't even work well when moist. So you need to find some type of isolation for that. Um, Another great example is physical training. In the Army, yes, we did physical training even as dentists. My last year in the Army, I had to do two physical fitness tests. The Army physical fitness test, running push-ups, sit-ups. Uh,
Yes.
Not much chance to, or not much, nobody's telling you to do that in a civilian sector, except maybe my wife. My wife keeps telling me I'm not allowed to do that.
So wait a minute. So that's interesting. There are, I guess, foundationally in dental school, yeah, isolation is really important. But the physical part, how does that change the environment, or how does that change the way you operate and perform in the clinic?
Well, ways it changes how we operate or how we perform in the clinic. One is you really have to have a great assistant team. Um, in the military, typically you're booking, a chair and a half, two chairs. Um, and in private practice or the civilian sector, I've been in places where a doctor's working three chairs. Well, you're not going to do isolation if you have three chairs and one assistant. You need that assistant team who can put on or place the isolation system, who can remove it, who can kind of be with the patient, because you put a lot of this material into a patient's mouth and they're just, I mean, it can make them uncomfortable, especially if they're in there alone. They like to know that somebody's there kind of keeping an eye on them.
Yeah.
Uh, you know, military dentistry as a whole, military medicine, gets a bad rap. I mean, I've talked to lots of people who say, oh, you were an Army dentist, and they aren't saying it in a flattering manner. But I'd like to put up the dentistry that we do in the that's done in the military, not just the Army, against any dentistry really in the world, unless you're doing it in a institute, a Pankey Institute, or something like that. One, we have peer review is a monthly occurrence in the military. Every month, somebody's going to look at my 5 of my records and see not just what I wrote, but was it treatment appropriate for what was diagnosed and planned.
Oh, so wait a minute, wait a minute. So it's like dental school. Someone is constantly watching what you're doing, or
Well,
not watching, but reviewing.
yeah, it is. It's kind of like dental school, but it's not, in that the person reviewing your records might be 2 grades in 12 years, you're junior. When I was at least a lieutenant colonel running a clinic in Fort Belvoir, Virginia, I mean, I was the only lieutenant colonel in the clinic, and I had 1 major and captains, and so there were several months the captains, who again 12 years my junior or more and 2 grades my junior, are reviewing my records. And you don't take an ego into it. You take, this is about quality of care. Another great thing about the military is the number of board certified specialists, including general dentists, that we have in the military. Now, part of the reason people seek board certification is it pays more to be board certified. But the the quality of care that tends to come out of a board certified dentist, I won't say is higher, but is consistently more predictable.
Wow, there you go. Wow. So hold on a sec. First of all, that's that's kind of huge when you think about it. In private practice, how often does an owner dentist get quote unquote reviewed by an associate who's been there, or who has 10 plus years less experience than they have, and kind of taken looking at what they're doing, and I almost questioning and saying, time out, what is this? Wow, that's a big difference, right?
Well, in my experience, because right now, I mean, we didn't get into what I'm doing, but I did 24 years in the Army, retired in 15, did a couple years in the VA, and the same thing happens in the VA because it's still a government service, government agency. Left there, went to a practice where I was the only dentist, and primarily I was working with a dentist in Washington State who, they did the denture work. I placed implants, extracted teeth, things like that was most of what I did. And then I went to start a residency in Olympia, Washington, and due to COVID, that kind of got shut down. It finally is up and running, but I had left Washington before it ever got going. But here in doing locum tenens dentistry, I've been into, I'll say, at least 15 practices here in the state of Tennessee.
Wow.
And in none of them do they do peer review or quality control.
So that's a huge wow. It's interesting to think. To your point, when they say, "Oh, you're an Army dentist," there is almost a mindset, and I appreciate you kind of debunking this. That kind of dentistry is different. It sounds like there's even more structure, and it continues through. What about technology? What technologies? I don't know if there's a perception, or I don't know if you could share the perception. Is there more or less technology coming from military dentistry and going into basically,
I don't know
private practice?
I don't know what the perception would be, Rolando, but what I can tell you for sure is that many of the Army clinics, the closest one to me would be Clarksville, Tennessee. And I know Dr. Mike Kroll, Colonel Mike Kroll, is the director of that program. And they've got CAD/CAM design stations at every doctor's office. They have multiple 3D printers, milling machines, and scanners. So I think the technology in the military sector is really good. Uh, the, I know because of what my wife does that they're really kind of driving the data and the metrics.
Wait, okay. Data and metrics. What do you mean by data and metrics?
She'd be a better one to ask that question too.
But
But
it's just monitoring what specifically the
well,
outcomes.
it's a not so much outcomes as productivity, ways
Hmm.
to increase productivity by looking at what's done. And this is actually growing. You'll find it growing, especially with the growth of DSOs. That a lot of DSOs look at the metrics that are done by their doctors. How productive are they? Um, you could do nothing but cut class one uh, cavity preparations all day long, and fill them, and be really, really busy. But are you being really, really productive? Some doctors could be, some doctors won't be. And this
Hmm.
is part of the reason I think, especially in a lot of private practice settings, because staffing issues, and that's across the board, but staffing issues and really you're driven by making a buck. And you have to be, because if you aren't in a DSO, they don't want to keep you around. In a private practice, you're going broke if you're
You,
not making a buck.
you hit something that is so. I mean, and it's something that that's everyone seems to be talking about, and this is efficiency and productivity. I guess in the military, it sounds like you're assigned or soldiers are assigned to go to the dentist, unlike the private practice where there's this whole context of attracting patients, trying to get them in, cycling them through, treatment planning. How do those compare to the two when you look at this issue of productivity, efficiency, those kinds of aspects?
In the military, there's such a thing as medical and dental readiness, or dental readiness is part of medical readiness. A service member, a soldier, a sailor, a marine, an airman, has to be fit to be deployed, to go to war. And to do that, there are certain measures that have to be. One is, I'll just stick to my specialty, which is dentistry. Uh, Within dentistry, they have to have had an exam within the last 12 months. They have, and sometimes they'd like it to be 12 months from when they're due to return, because they don't necessarily want them to have that exam during the deployment. Now, things happen, they get deployed, have exams during deployment, but that's not the expectation. They also have to have a Panorex in the record. Medical things go into things like, well, they have to have a DNA sample. They have to be able to get their medications. If they have sleep apnea, they have to have some type of it used to be a CPAP that they would actually deploy with. Now they can make oral mandibular advancement devices. So dentistry in the military has picked up a big part of that, and making these oral appliances to help service members who have sleep apnea.
Wow. It's interesting. You never think about it. I guess my perception, I'll only speak to myself, is that in the military or armed forces, it's about getting the patient in, making sure that they're in a good place, and that's it. And it sounds like it's a much more expansive thing, and the amount of all the other aspects of it that are incorporated into that that's something completely new to me. I really appreciate kind of clarifying what that looks like.
Not a problem. And it's really not a matter of just being fit, but keeping them fit, putting them in a position where they can maintain their own wellness, their own oral health. There's other advantages in the military that we don't have in the private sector, is that uh, patients don't have to pay for their work. So
That's a
you,
big thing.
oh, it is a big, big thing. Um, but because of that, you'll have some patients will show up with very much unrealistic expectations. Um, you know, a two-pack a day smoker who's, also diabetic, and yes, we have these in the military. Once that implant placed, where number 19 was lost, um, for those of you who don't use the US system, it's the lower left first molar. But they've lost that tooth. They want an implant placed in there. Well, they aren't going to meet the military standard to have that implant placed. They're given other options to do that. But it's really nice to just be able to develop an ideal treatment plan based around the patient's needs and expectations, not so much based around what can the patient afford, what can they develop, what can they
Yeah.
qualify for with a credit and their own account. And it is the world's best dental insurance because it's not capped.
So as long as you're in the military, if you need any treatment, you can get it. It's a matter of making sure, or being not qualified, but having the being able to be in the space to do that.
Right. Well, there is all, sometimes we've had cases where patients in a remote location where there isn't a doctor there who provides implants. And so then it's a matter of referring them to the nearest clinic. Well, sometimes the nearest clinic who places the implants. I'm going to go to when I was stationed in Germany my last time. The nearest clinic that placed an implant was over 3 hours away.
Oof.
So, but if the patient qualified, they got actually paid to TDY to drive to that location. And if it was the possibility, like they had a 7 o'clock in the morning appointment, well, they probably get their hotel the night before as well, and per diem
That's pretty cool.
to cover their meals. So, I mean, it is a pretty good deal. However, the downside to the doctors and to the patients are the other military expectations. I mean, not everybody's cut out to be in the military for 24 years, and I didn't think I would be when I joined.
That's a huge thing. I'm gonna shift gears. I'm curious. It struck me. If you look at the top three technologies that you had in the military that may or may not be as prevalent in private practice, what would those be if you were to kind of sum those up, and why? Why would you say those are so key?
Um, well, again, I retired almost 10 years ago, Rolando, so
Well,
you'll have to excuse, but at the time, um, I think the military was an early adopter of digital radiology. And part of that is that database could be centralized um, in one location around the world, really, where those could be the images could be downloaded, stored, which would really help with identification of a patient. God forbid they died, but it happens in the military. Um, we were I think the military did a great job keeping up with and trying to stay ahead of the curve with CAD CAM, both CEREC imaging, because CEREC was the primary system we used, although early on we had, there was one prosthodontist who, he actually was testing every system to see which one they thought would work best. And although it's not really technology, I think something I really appreciated the military did was standardization.
yeah.
At the time we had, when I retired, we were allowed to use two different implant systems. One of them was a 3i, and the other one was a Nobel Biocare. And the issue we had was sometimes they would change their equipment, which would change platforms or change things like drivers, but you don't want to put in an implant in post A, have the patient travel across country and find out that system is not
Different.
in post B. I've just run into that with a office I've been working in Knoxville, where the implant that was placed is not the implant system that the doctor commonly uses. So we're almost have to refer the patient out for restoration of an implant, or they have to buy the equipment to do it.
Wow. So standardization, the technologies, the radiograph, that type of stuff. Are there any things that you wish that the private practice would adopt that they currently don't?
Not a technology, but I would really like a lot more practices to use isolation. I walk into practices on a regular basis where isolation is an afterthought, or it's cotton rolls, cotton rolls and dry angles. And neither one of those stop the patient from breathing. So I frequently tell the patient, well, if you could just hold your breath for the next 30 minutes, this filling will probably last you a long, 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 long time.
30 minutes.
But most patients aren't capable to do that for 30 minutes. So I mean, I wish a lot of private practices would just adopt and use more glass ionomer, hybrid glass ionomer hybrid materials to restore teeth as opposed to composites, um, because the way they're doing them, for the most part, I think they're going to work out and patients are going to get a better result. And the doctor's probably going to spend less time chasing things like postoperative sensitivity, et cetera.
Yeah, it's I love it because you've seen kind of the best of both worlds. Let me ask you this: for private practice, because the military has an incredible population of dentists, and they get to treat a lot of people and see a lot of different circumstances. What advice or what feedback would you give a private practice owner, owner dentist, with regard to bringing on somebody who's retiring from the military, or somebody who's finally finished up what they're doing in the military and coming out? So a military dentist, what advice would you give with regard to working with them, or are there things you want to look for with regard to that kind of skill set?
That's really a great question. So if I was had my own practice, I was bringing in somebody who was separating from the military, not even necessarily retiring, even if they just served for 3-4 years. Um, Understand they probably got a different skill set and expectation. Um, I would During my military time, I never had to sell a treatment plan. Um,
Hmm.
I
That's
did
a
not
that's
have to
a
worry about counseling, financial matters and things like that. And I realize that that's a big thing to have. That's a great advantage. Um, so I would definitely team them with strong assistance there. I feel most dentists, myself included, benefit from good mentoring. Uh, Whether you're going to hire that military person or not, find yourself a study group, a group of dentists that you're comfortable with, who you can be mentors, and they shouldn't all be your classmates and immediate peers. Go 10 years older and go 10 years younger, because
ah,
you go 10 years older, 10 years younger, well, the younger people might have more of a grasp on technology. They might have more of a grasp on how to relate to a
right.
younger patient population. The older doctor, especially if they've got that military background, or bring a knowledge base that you weren't taught in school. School teaches you how to pass your boards. Um,
Right.
Dentistry
Right.
teaches you how to do dentistry, and whether
Yep.
you're doing your dentistry in a residency, in the military, in a private practice, you're going to learn more. Your curve is going to be steeper. Your learning curve is going to be steeper if you've got a good mentor or two. It's going to be incrementally steeper if you have a great mentor or two, people that
Yeah.
you're comfortable with and they're comfortable sharing with you.
Dr. Holzer, you mentioned something, and I love it because I believe this is the first time I've heard. A lot of times people talk about mentoring, and they say find somebody who has, the experience, but you say find people who have a lot of experience, who are many years, who've had more years, and also spend the time with the people who don't, because they both bring to the picture, or bring to the party, a different kind of skill set. I love the context around that, the younger dentists and the way they interact, and maybe technology. But there's also something to be said for the institutional knowledge that an experienced dentist who's had many years, because I think about this. If I needed some pretty complex work, would I want to go to somebody who's done it 5 times, or would I want to come to you who's done it 500, 5,000 times, right?
Well, right, but just because a dentist is older doesn't mean he's done it that many times. Um,
Right.
I'm trying to think. I graduated my residency program in 2000, and it was from 2000 to 2010. So I placed 2 implants in my residency program till I placed my next implant. Um, and so that was my third. And I've done hundreds since then, but it's just a matter of being in the proper location, the proper place. Uh, if you are a doctor who, say you love doing molar root canals, but you're stationed at Fort Bragg, North Carolina, or it's not Fort Liberty, North Carolina, or in Augusta, Georgia, and I'm not going to remember the updated name to that, so I won't use the old one. But if you're stationed there, the chances of you getting to do that molar endo, unless you're a endodontist or an endodontic resident, is really small because they have endodontic residency programs at those two locations. So, I mean, like I said, it really limits your ability sometimes to gain experience just as a
Yeah.
dentist, unless you can get kind of a one-on. I was very lucky. I always had, I feel, a good command team who supported my desire to learn, a good access to who I consider strong mentors to work with. There were others who I did not feel, as strongly about. Well, you just kind of avoid those, but you have to have
Yeah.
that ability. Um, if I've done work on cars, I'm not much of a mechanic, but I've done some work on cars, especially as I bought inexpensive cars for my son as he was growing. And you could go on YouTube and learn how to change a cabin air filter or a cabin heater fan. But that there's one way to do that, and they all, from a Kia Sportage of 1990 to a Kia Sportage of 1990, they're all pretty much the same. Well, they're exactly the same, but every patient, every tooth,
It's
every root canal you're going to do is different. And so because of that, it helps to find, you can't just, I don't think you can look it up on YouTube and learn how to do it. It's not like placing isolation. Isolation you can learn how to do, on YouTube. Cutting the proper cavity prep or crown prep is not really YouTube, or in my never humble opinion, something that you learn by calling the buddy you graduated dental school with, who has basically the same amount of experience and dentistry under their
as you
belt as
do.
you do. Right.
Oh wow. It's fascinating to think about the breadth and all the different aspects of it. If I were to ask you, for our viewers, for people listening to this, to kind of sum up and marry the experiences that you've had in the military as well as the years in private practice, and kind of sum that up, how would you sum that up for our viewers, for people listening to this, and what advice would you give them with regard to considering the things about that?
Um, that's a really good question. To sum up, uh, remember, although you learned how to pass boards in dental school, a lot of what they teach you about passing boards is important when it comes to doing the very routine elements of dentistry. Things like isolation, proper preparation technique for the restorations you're going to do, crowns, bridges, things like that. Your pros learnings, the rest seats. I'd say always, even if you don't have somebody looking over your records, always pretend that you're going to be out of your office for the next 6 months. And another doctor is going to come in behind you. That doctor might have much more experience than you do. Would you be embarrassed to have them look at, if you knew they were going to look at your work, would you be embarrassed by that? Or your notes? Are your notes complete? Little
Mm,
things like that can really help protect you. Uh, and it makes you a better dentist if you think somebody is going to come behind me and look. The
yeah.
patients don't know. The patients know, do you smell bad? Do you have a pretty office? Do you take their insurance? Uh, do your hands shake? And are you confident? Another big thing that I think luckily I've been blessed with is kind of an overabundance of confidence. Some would say I'm cocky. Some would say
No.
I'm conceited, but I'd like to think I'm just very self-assured that I do that. And the other thing is, if the patients know that you care about what they care about, um,
Yeah.
how you care about them is a lot more, what do you think about what they think is really important um, for you and for the patients. It really helps. Uh, what is it? If nobody cares,
Cares
right,
how much you know
right, more than they
until
know,
they know
they
how
should know
much
how
you
much you
care.
care. Exactly. Thank you, Rolando. I appreciate your help with that. it's a very important thing to bring across. I mean, these are things that I would tell a young doctor or a doctor separating to, people leaving the military. You can't walk in, and I've had this problem, really walk into it. Luckily, I had that VA experience, the private practice all by myself, where I'm confident, but I think for the most part, I can go to a doctor and say, hey, here's some things I'm seeing, bringing my experience to the table that might help, that you might want to consider adopting. I do a little teaching, a little speaking on the side, primarily talking about the glass ionomer materials, because again, I don't think I'm going to get the world to adopt using proper isolation. Uh, it's a fight one at a time, but I could go
Never
to,
give up.
right. Well, I realize that. Thank you. But I said, and they, again, the ISO light, ISO dry has made this much easier to do proper isolation. And, for things like immediate dent and sealing, for bonding crowns and bridges, it really makes a big difference in the success. I see a lot of crowns that come off, and I know how the doctors are doing the, cementing and bonding their crowns, or their, even some of their bonded fillings, and seeing them come out. It's like, thought just goes through your mind. If only proper isolation had been used, this would still be working, and your patient would be further ahead.
And you got to use you got to use our systems in the military because we're partnered with you also.
Very, very much so. I was actually on board, and I can't remember the young lady who was ahead of you, who came to our clinic at Joint Base Lewis McChord and brought this up. And I mean, I know when I was early adopting, doing what are referred to as Richmond crowns, but a patient, they're deploying in a week. They need a root canal and a new crown on tooth number 19. Well, the endodontist sits down, or you sit down and do the endo on number 19, cut it down for a crown prep, and next thing you know, the crown's in there. Well, you might be doing the root canal with rubber dam, but the Richmond crown is all done with an isodrying system. You do have to turn off the light because that's why I said ISO dry. You have to turn off the light because the light will cure your bonding agents. The light in ISO light is pretty bright. I don't know if you guys have made that adjustable, but I do think, like I said, it's things like that are just wonderful. They're I don't look at them as technology. I just look at them as common sense.
Oh, wow. Well, I appreciate it. So hold on. I could spend the rest of the day talking to you, but I want to be respectful of your time. If people wanted to reach out to you and ask you questions, or wanted to just chat, is that something you'd be open to doing?
I would very much ask that people be respectful.
Yes.
Realize that what I'm saying, none of what I said today is based on science. It's based on my experience and my personal preferences. So if you want to troll me, don't bother. You won't affect me.
I love it.
Yeah. I've got an email, george.holzer@gmail.com. Rhonda's going to flash it up there, and because we talked about this before. And I think, like I said, if you just wanted to chat, talk about my direct transition, although again, it was 10 years ago, and I did not really go directly from military to private practice. Like I said, the VA time was a great transition breaker there. And now, because of my military retirement, I just do locum tenens fill-in work throughout the state of Tennessee. Tomorrow I'll get in my car, drive 150 miles, I think it is, to Knoxville, and work in Knoxville for the week, and then drive home and spend the weekends with my wife.
That is awesome. Well, first of all, having the experience in the military and then also years in private practice and being able to marry those are huge. Really appreciate the insights that you've been sharing with us here, the context around mentoring and the context around, come into a practice and imagine that you'd be leaving in 6 months, and would you be embarrassed if somebody were to look at the work you've done, or even the notes, which is something that doesn't happen. There are these different aspects, and I think part of what you bring to the table is that experience and that. So really appreciate you taking the time to spend with us today. Really appreciate kind of the context that you're setting around it. As you're a colonel in the Army, and you think to yourself, "Oh no, this guy's going to be really scary." No, you're not. There's a genuineness to the way you look at things. You really care, which I love, and I really appreciate you taking the time with us here. And again,
You're
sir,
funny when you say that about being a colonel in the Army and scary. I think the most I ever scared a patient was actually when I was a captain and I had a young patient reach up. We were doing a dry socket dressing, and the patient was having some discomfort. He reached up, he grabbed my hand, and I basically just said, "Private, your grass grabbed the captain." I wouldn't recommend that anymore. He did let go. We talked about it. Uh, and yeah, I try not to pull rank. And since I've retired, I've kind of left most of my rank alone. I do have military contacts, and of course, I have many military friends that I keep up with. But as far as like I don't even think I fit my uniform anymore, Rolando.
but I want to. Okay. Taller this way or taller this way? Okay,
taller.
I'm not going to touch it.
We're saying taller.
Well, first of all, Dr. Holzer, Dr. George, thank you so much for joining us. Really appreciate it. Hey, folks, if you have any questions for Dr. Holzer, please feel free to reach out, send him an email. And yes, be respectful of that. No trolls. That's no good. And, there's so much that I'm sure that we haven't talked about that he could share insights into, and really appreciate it. Again, for you, Dr. Holzer, thank you for your service, over 24 years, as well as all of our military partners. Really, really, really grateful for what everyone in the military does. So, and if you like this content, and if you want to reach out to Dr. Holzer, feel free to do that. If you love it, share it, let people know, and then let us know how we're doing. If you have any questions about it, and we look forward to seeing you in our next episode. Thank you, Dr. Holzer, for joining us, and really appreciate what you're doing, and look forward to seeing you again.
Thank you, Rolando. I appreciate the time.
Take care, everybody, and we'll see you in the next episode of Dental Voice. Take care.